Hello, everyone. We'll talk about metabolism and excretion. Do all drugs have the same metabolism, or do they have the same excretion profile? They don't. Let's talk about the outline of this slide. We'll first talk about the processes, then we'll talk about the biotransformation, then phases, and an important enzyme, which is cytochrome P450, what is intrahepatic shunt, loading dose, and maintenance dose. First, let's talk about what are the various parameters that we have. We have already studied this. Drugs, absorption, that goes into the systemic circulation, then into the distribution and elimination. When it comes to the distribution, pre-fraction and volume of distribution are important. Whereas when we talk about the elimination, half-life and clearance are important for us. The two main processes of elimination are biotransformation and excretion. What is biotransformation? Let's split the word. Bio and transformation. The drug is transformed into a different chemical entity. Whereas excretion, the drug, which is the metabolized form of the chemical, is transferred outside the system. That could be by urine or by feces. What are the pharmacokinetic parameters which are related to this? Elimination rate constant and clearance. From the name itself, we understand that elimination rate constants is the quantifying factor for the rate of disappearance of the drug, whereas clearance is about the organ's ability, the kidney's ability to take it out, or the liver's ability to eliminate the drug. So that is what is clearance. What are the characteristics of elimination process? Usually disproportional to the plasma concentration. What does it mean? Higher the amount of the drug in the plasma concentration, the elimination would be higher as well. Therefore, the elimination rate constant would be important for us, but we need to remember that metabolism is not linear. It is irreversible and only free drug can be eliminated from the blood or the plasma. Let's look at this one. We have a xenobiotic. We have two phases, phase 1 and phase 2. And phase 1, it becomes a metabolite. From the phase 2, it becomes a conjugated metabolite. What is conjugated metabolite? It conjugates with the metabolite. So there are some conjugation factors which come and add up to it. But what is the ultimate goal of it? Increase in polarity, more solubility in water. Then it can be excreted out. So that's the basic idea of why we need metabolism and excretion. Biotransformation, the drug is metabolized. And as we already saw, less lipophilic. What is lipophilic? Lipo and philic, which is less fat soluble. And therefore, the examples of the metabolites which are active are L-DOPA is converted into dopamine, which is used as a Parkinson's drug. Metabolites can also become toxicity. Examples, cyclosporin A have renal toxicity. And metabolites can also be stereoselective as well. What are the different types of phases that we have? We have two phases. The first one, it introduces or exposes a functional group. Example, oxidation, hydrolysis. Phase 2, it's the formation of a covalent bond in conjugation reactions with the glucuronic acid. Examples would be morphine or the salicylic acid. So that's how it would be. Let's look at some of the examples. We've spoken about, there are some prodrugs. Example, the chloral hydrate, that is reduction, which becomes trichloroethanol, which again on conjugation becomes trichloroethanol glucuronide. And this is another example that we have. We have phenytoin, which on oxidation becomes para-hydroxyphenytoin. And we also have other examples where we have. Let's look at one particular example, aspirin. That's converted to salicylic acid. And that salicylic acid on conjugation, look at the different things that we have with the conjugation. Salicyl acyl glucuronide, salicyl phenolic glucuronide, salicylic acid, and genticin. These are the different conjugations which are all possible with the aspirin after it becomes the salicylic acid. Next, we're going to talk about an important enzyme, which is cytochrome P450. If you look at this one, this is the main constituent, and cytochrome P450 is present in the liver and in the GI wall. It's a superfamily of enzymes, and it has this heme cofactor, which is highlighted over here in the orange. and that functions as a monooxygenase. As we said, it's a super family of enzymes. It's not just one single enzyme. That's why it's given us all the components, major components are given over here. With this arrow, we are signifying that there is a significant risk of drug-drug interaction. Talking about drug-drug interaction, look at this. Drugs A and B, they are metabolized by cytochrome P450. And these two drugs were given simultaneously to the patient. Drug A is a prodrug, whereas drug B has a higher affinity for cytochrome P450. There are a series of questions. How will you go about answering it? Look at the bottom. If a drug is in the plasma, the efficacy of the drug is there. And then when it gets metabolized, it becomes inactive. So there is no efficacy. Get it? For example, let's take that you're taking Panadol and you have the Panadol inside the blood, then it gives you the relief of the headache. Whereas when it becomes inactive, there's no activity for it. Therefore, it will not reduce the headache. However, if we have a prodrug, what is happening is that the prodrug will be converted into the drug, which is the active form of it, to become efficacy. Therefore, it is efficacious. But when it again becomes a metabolite, then there is no efficacy. So that is how the efficacy of the drug would be calculated in these cases. So we need to think in those lines to talk about these questions. Next, we will talk about enterohepatic circulation. What is enterohepatic circulation? Let's look at this flowchart. We have a drug that goes into the gastrointestinal tract and then into the liver. So what is happening in the liver? Sometimes it will be taken out into the elimination. And then from the liver, it also goes into the tissues. Now, if you look at it, the arrow goes backwards, stating that from the liver, it goes back into the gastrointestinal tract, which is called as the enterohepatic circulation. What are the drugs which do follow these methods? Chloramphenicol, aspirin, paracetamol. Let's look at another example over here. If you look at this one, same thing we were talking about in the previous slide. Multiple peaks in plasma level time curve in the pharmacokinetic profile of a drug can be due to enterohepatic cycling of the drug. What is this? The drug enters and then it goes into the gut, then it moves off again into the liver, then comes back through the bowel to the gallbladder from the bile duct. This is going to be there. For example, look at this one. Entero means intestine and hepatic is liver. That is why it is called as enterohepatic shunt. Next, we will talk about elimination. In case of the elimination of the drugs, there are major and minor organs. In case of the major, the kidneys and liver, they play a very vital part. Minor ones are the lungs, mother's milk, sweat, saliva, etc. In case of the excretion through the urine, phenobarbital. Remember when we have the Olympics or any of the events for the sports events, then what do they have? They have the test for the urine to test whether the athlete has taken any drugs. So that is how they test it, because it's being excreted in the urine. Next is the lungs with the alcohol. When a police officer is suspecting the driver has taken alcohol, then what do? They take a breath analyzer and keep it on the nose to find out whether the alcohol has been consumed or not. Why? It's because it's excreted through the lungs and it comes out. Breast milk, saliva. When you go to your Starbucks or any other coffee place that you really like, after you take the coffee and after about an hour or so, you still have a feeling of the coffee in your throat. Why? It's because it's being excreted out through the saliva as well. So these are some of the examples that we have. Elimination through the renal excretion. There are three main processes: glomerular filtration, proximal tubular secretion, reabsorption. And there is a key issue in renal impairment and dialysis. If there is a renal impairment, one of these processes or all of the processes would be hampered. Therefore, it will become difficult for the drugs to be excreted out. Therefore, we would be needing dialysis. We know about glomerular filtration. There is passive filtration and only free fraction can be filtered out. So this is how the diagram of it looks like. In case of the reabsorption, the average pH is about 6.3. When we have the alkaline urine, you can do this by adding in acetaldehyde, sodium bicarbonate. If you want to acidify the urine, you can add in the ammonium chloride. If there is alkaline urine, what would happen? Weak acids will be eliminated better. Whereas in case of the acidic urine, weak bases will be eliminated better. In case of the basic urine, unionized weak acidic drug is present. Therefore, there is no absorption, reabsorption. High elimination of the weak acidic drug is present. In case of the acidic urine, it is just the opposite. So what happens when there is renal impairment? Think about it. Think about the three processes that we spoke about. The final one that we are going to talk about is bioavailability. So we have a dose of the drug which is given. It goes and destroys. Some of it is destroyed in the gut. Some is not absorbed. And some of it is destroyed by the gut wall. Then some is destroyed by the liver. Then it goes into the systemic circulation. Let's say that you give 100 milligrams of the drug as a dose. How much is going to come into the systemic circulation if it is given as the oral dose? How much is going to come in? Probably about nanograms or picograms will be coming into the drug, into the blood. So that is what is called as bioavailability. Let's look at it in a different manner. So we have the dose. It's destroyed in the gut. Some is not absorbed, destroyed by the gut wall, by the liver. So all these processes take place, and finally, when it comes to the systemic circulation, that is what is called as bioavailability for us. We know that the amount of the drug which is present in the plasma concentration, which is the bioavailability, is the one which is going to give us the effect. So when we talk about it, we make this into three ranges: subtherapeutic, therapeutic, and toxic range. So we want the drug to be in the therapeutic range. In this case, we have two methods by which we can get the drug to the dosing that is necessary for us in the therapeutic level. How can we do it? The first one is single dose, which is a loading dose. So that you give it a higher dose where it can go straight away into the therapeutic level. Or the second method, repeated doses, where you have a little amount of doses, which is increase and increase till it reaches the therapeutic level. So these are the two methods that we have, and this will help us to go and reach the therapeutic level. So remember, we have absorption, distribution, metabolism, and excretion. Every individual dosing that we give to the patient, all these processes are qualitatively similar in all the individuals. However, because of various reasons, the quantitative aspects differ considerably. Therefore, it is very important for us to adjust the doses according to the individual's needs and the biochemical processes which are taking place inside the body of the patient. Also, we need to look at if there are any additional disease conditions we need to think about for the patient. So that is what we have for metabolism and excretion. I'll see you in another session then. Bye.